very much, Professor SOAR, for inviting me. I'm very happy to be back home. But as he says, I have been keeping on coming, and as you see what I'm going to present about, it's the work that keeps bringing me back. So I've been out actually since 1992. It's been a long time working with these international organizations. But the main thing has always been to initiate programs. The reason why the World Health Organization took me from here, I don't know whether Professor Ankabo knows, is because at that time there was no treatment for AIDS. And other countries that the World Health Organization was giving advice to did not know what to do with a person living with HIV. So when they came to us in TASO and they said, are you able really to face a person living with HIV and you tell him that, yes, your blood was tested and has a virus that causes AIDS, and you face him and tell him that, and then after that, you continue talking with him or her, and you continue supporting them? I said, yes, we do it. And that was the only reason they took me to WHO. Because they were stuck. The countries they're advising are countries that didn't have any resources, and they didn't know what to do with people with AIDS. So the aim was, can you tell them what you can do with the little you have, like drugs for treating symptoms, and then you still look after a person living with AIDS without just rejecting them and neglecting them. So anyway, so all these programs that we were developing, the issue was that they needed to be translated to other places. So the concept of operations research came up, whereby it was actually intensive monitoring and evaluation of a program. And then you produce that report, which shows other people that this program works. That was a simple thing that I was doing all the time, that it works, that TASO works, that people can come, they are treated, they are seen, and they keep coming. So we just showed the numbers, and that was it. So that's why the concept of operations research comes in. It is not as elegant as it is, as the research is, but it's what runs the programs. People need to see the numbers, they need to see how they work, and then they use that. You go to scale, you expand. Okay, that was my way of introducing myself. So let's go now to the presentation. So the presentation, my presentation is in 3 parts. One is the 7 practices of SOAR's research utilization approach. I'll tell you what SOAR is. Then I'll give you an example of Uganda ART shifting study. I'll use it to overlay the 7 practices so that you can see how it works. And then we'll give recommendations to you as a research institution on integrating RIU into research. First of all, I'm also very happy that I'm talking to you. You all look relatively young, and so you are getting into the career of research. So it's good that we get you right from the beginning, what Professor Ankabo was talking about, so that you can focus, look at research with the end in product. And the end is really improving programs and services. The paper is one of the products, yes, but that's not the end. Okay, so SOAR is a USAID funded project. I'm sure you're familiar with USAID funding a lot of our work, and every 5 years they advertise and people, organizations compete for these projects, and those who win, then you carry out these projects according to the proposal that they submitted. So our group submitted that. Our group is this one, and we won that project. But I want to say that we have been winning since 1998. The HIV operations research projects of USAID, we've been winning them since 1998. So the first one was called Horizons, then it was followed by something called Search, and then HIVCOA, and then now we are in SOAR. But they are all on the same principle, the principle of doing what I call intensive monitoring and evaluation of a service delivery program, and then we're going to scale with it. So this particular one is 2014-2019, and we are so far in doing 60 research studies around the world. We have $50 million, and this is the consortium. As you do more research, you realize that you don't work alone, it's collaboration. So we always have consortiums of organizations that work together. So these are the countries where we're doing research, and as you can see, Uganda, we're here with seven studies. I'll tell you which ones they are, but you can see mainly where the HIV epidemic is really working is most intense. So right from Ethiopia down to the Cape and going up this way. So that's where we intensify the work. So which are the studies in Uganda? We've got Professor Philip Msoke's study is here. Disco, she will explain about it. Then we've got pediatric case finding by EGPAF, by Elia Natumanya in Imbarara. Then we've got PrEP modeling, which was done. Modeling is really just mathematical modeling, so there's no site as such, but it was done in collaboration with the Herbert Kadama and then Timothy Mwonge. Then stigma index, which my sister Stella will talk about. And then we also did modeling VMMC, voluntary medical male circumcision. Joshua Msingi was the department president who represented the MOH, and then Mwidu was from Motarin. Then there's what we call preferred geographical prioritization. So again, Sembola was the one who participated in that. These, I think there are 6, but I think there were 2 of these, the modeling ones. So those are the studies that SOAR has in Uganda. So you see, there are quite many, but the whole aim is the same. Okay, so let's now look at the research utilization strategy of SOAR. So when USAID gave us this project, they gave us these 3 objectives to meet this need. And the need is improve HIV/AIDS program outcomes. So I want you to know that. I know this is an academic institution, but the aim was not to generate knowledge on something and publish it, but to improve program outcomes. And that's really the key point through operations research. So one, we conduct the research. Of course, it has to be high pointed. The other part is strengthening the capacity to conduct and consume operations research. So we go around meeting partners and talking to them about understanding the research. Then finally, the last one, which is what we're focusing on now, is promote use of study results to guide planning, funding, and implementation. So, focusing on that, one, of course, is that they have to know the results. So effective dissemination of operational research findings through multiple channels is the first step. So publication is important. Going to conferences, sending conference abstracts, having meetings, and so on is very important. And the Stella and the Philip and President will talk about how they're disseminating. Then we need to changes to practice and policy due to SOAR activities. That's really very, very important. We want to do research which informs practice. People will learn things every day, and how does that improve practice? And then we need to track how the research is improving practice. And the reason why we track is that the people who fund research are now asking, why do we waste so much money? You see, now we're given 50 million. Why do we waste so much money conducting research? What's the benefit of it? Why don't we just use it for ARVs? So we have to track and show evidence that our research has a benefit. So, what are the dynamics regarding research utilization? Let's look at least 3 groups of stakeholders. Let's look at here, programs. Programs, the program managers, they're practical, they're urgent, and action-oriented. That's how TASO was started. They didn't ask what is the evidence that when you set up an AIDS center, people will come. They had no evidence. They didn't ask what's the evidence that when you talk to people living with HIV, they can improve their own lives, what we call positive living. There was no evidence. But they had to start. They have to start somewhere. They don't wait for evidence. On the other hand, we have the policy makers. Here in Uganda, the key example I can give you when the policy makers were in the problem was to do with condom use. So evidence was clear that condom use should be promoted because it prevents HIV transmission. But religious leaders were up against it. And so policy makers just had to bargain. The evidence is clear, but some stakeholders are up against it. Then research. Research is controlled, empirical and objective. So that is another group, you, the researchers. You want everything to be controlled and organized. And so when we come to say, can you engage stakeholders at the beginning of your research, you're going to say, but I've already determined I've talked with my professor, we determined our key research question. Now you're telling me to go and talk to those people. They're going to propose other things and they're going to disorganize my protocol. So you want everything controlled. But life is not like that. Life is not controlled like that. So in this sense, research utilization involves all these working together. Understanding the context and then engaging stakeholders to support use of findings and to build ownership because your research has to be owned. Okay, so let's go now look at your research proposal. You know, when you write a research proposal, there is the introduction, the rationale. Somewhere at the end of that introduction, you are supposed to say the expected outcome of your study. So, I know that contributing scientific knowledge is clear, isn't it? So you are contributing, you have identified the knowledge gap, and you say your study is going to contribute to provide knowledge for that, to address that gap. Building your career, of course, is the hidden agenda, isn't it? You want to have as many papers as possible. Yeah. But the most important reason, which you tend to forget, is contributing to the body of evidence upon which policies and programs in the country are based, and internationally, that's what they are based on. I worked in WHO, and that's what we're using. Studies from Uganda and elsewhere were the ones we were combining together to develop the WHO guidelines and policies. So you have to contribute to that. Otherwise, if you don't contribute to it, WHO will be empty-handed. They will be baseless for them to begin recommending what they recommend. So, now, CIOMS is the Center for International. Okay, this is a big body that's responsible for ethics of research. And one of their guidelines, what they do, they say, is that in general, a research study should only be justified if its conduct and results will be of benefit to the community. Meaning you don't do research on a community, get the findings and go away. It is unethical. So your research should have a benefit to that community. So the expected benefits of the research to the community and society at large or contribution to scientific knowledge should be stated in study protocol. So when Professor Wankambo with his ethics committee are reviewing their protocol, they should actually look at what's the benefit of this research. Is it just a matter of just interest in knowledge, or is it of benefit to the community? So I was talking about your introduction to your protocol. It should state, first of all, the magnitude and the importance of the problem that you want to address. Of course, it has to be important. You get that from your literature review. And then the solution you're proposing. If you're proposing a solution, what's known about it and what is not known. Because that's why you're doing research. Research is generating knowledge. It's something that's not known. And then you need to state the current status of policies and programs that are addressing that problem. And then how your study will influence these policies and programs. So, yeah, just before I go to that, the issue is that if you're doing a study on PMTCT, do you know what the current policies and programs in Uganda are on PMTCT? Do you know where to find them? The policies? Anybody who knows where, if you want to find the Uganda's PMTCT policy, where do you go? Nationalist program, isn't it? So you can't finish that protocol without going to National AIDS program and asking who is responsible for PMTCT and what are the latest guidelines, so that you put in your protocol, study protocol, that these are the PMTCT guidelines at the moment, and the gap is as follows, and my study is going to address this gap. So that's really the key point. So what are the what are the steps that we have outlined in SOAR? One of them is identify key stakeholders. So like PMTCT, you have to identify the key stakeholders. You have to go to the Ministry of Health and you know who are the people who make changes in PMTCT programs here. There's a PMTCT maybe working group and so on. You must know them. So then you need to engage them during study design. You need to tell them, we are proposing to do this study. We want to address this gap. What do you think about it? And then they can reorient you and say, no, that's not the gap. The gap is here, or this way. Okay? And then you need to establish a research advisory committee. You don't want to do this research on your own. You need to have such an advisory committee which consists of all the stakeholders. And as you will see, instead of presenting, we need also to include beneficiaries. Because HIV is a very special disease in the sense that we have a lot of contribution from the people living with HIV. Unlike perhaps measles, there is no group of people living with measles. Okay? But with HIV, all the response, including the ARVs that we have today, we have them because we have activism from people living with HIV. So they must understand the science and they must understand what demand from the donors. So we must include them. Then we need to include stakeholders during data collection. For example, if the study is going to involve MSM, how are you going to find the MSM? Men who have sex with men, how are you going to find them? None of you have done a study on MSM? By who?
By themselves.
Yes, self-referral. Okay, so where do you find, when you say themselves, where do you find that themselves? Where must you go? Yeah, they have their organization, isn't it? So you can't do a study on MSM without engaging the organizations of MSM, isn't it? Because they are the ones who, first of all, they have to read your study, understand that you are doing it for their own sake, you are not a threat to them, and they own it, and then after that, they will begin guiding your research assistants. So that's very important. Then when you get the data, this is what we call data interpretation meeting. Before you go out too far, or even writing, you need to understand the percentages. You have numbers, you have answers to questions, but those answers, you'll be surprised when you talk to stakeholders what those percentages mean. For each one of them, they've got a meaning, which you, as a young researcher, you may not know. So you need to present the data in this raw form so that they can give you the meaning of those numbers. Then you disseminate in a meeting, and then you develop a research utilization plan. Now what we mean by this is that your study is going to end, your funding is going to end, but your findings should remain alive and be promoted by champions, what we call champions. So you should have a plan for how the findings will be promoted. And then after that, we implement that plan, and then we monitor how it is being implemented. So just here to tell you about SOAR's 50 or so studies. We are now 3.5 years. This was, I made this assessment in March. And so you can see that for the first two steps of identifying stakeholders and developing plans to engage them, we checked on our 54 studies, 89% of them had actually identified stakeholders. Then for the second and third, which is engaging stakeholders and convincing the research advisory committee, again 92% had achieved that one. The fourth one, which is engaging stakeholders in data collection, we had evidence for 84. And then for the data interpretation, we had evidence for 89%. And then the dissemination, so far, because there are few of them, we've had 45%. Then finally, those that have established the plans for ongoing promotion, we've got 47%. So that's my job, to monitor that, to continue going through, meeting the PIs and asking them whether they've done that, and them giving me evidence that they've done that. You see, research utilization can, on one hand, you can't force stakeholders to use your research, but there are some basic steps you need to do to ensure that they own the studies and they utilize them. Okay, so now, those were the principles. Now I'm going to give you an example here, based here at home, which now will show you how we apply this. So we did this study before SOAR, but again, we're the same group. We did this from 2012, 2015. We used it here as an example because it is completed and there's evidence of it being utilized. So we conducted this study. These are some of the publications for it. You go back to them. By the way, this presentation, I'll leave it with you so that people can share as they wish. So, first of all, the two practices of identifying stakeholders and engaging them. What did we do? I came here, I made scouting visits to TASO, which of course is my home organization, to Uganda Cares, and to Kitovu Mobile, and we are outreach. So I was going to do a study on task shifting. You know what task shifting is? Yeah. So I was going to do a study on that, but I came with just a notebook and pen. You know, you just come and ask people to talk to them. So when I met them, first of all, mere outreach, I discovered they had done many studies on outreach. You know, on task shifting. Is Wanyenze and there is Kalisuna, so they had already published a lot. So that was eye-opening for me. So they had done a lot about task shifting. So in the end, what I determined was that the key issue delaying task shifting policy was not whether task shifting was considered safe and effective. Already there were enough studies to prove that when you delegate ARV service tasks to lower level health workers, they perform them very well and they are safe. So that was no longer an issue. So I had to change my study. That was not the issue. The issue was for the government to put that in the policy, they needed to know more, how do you do it? How do you do task shifting? And what does it cost? So, also in my literature review, I had also found that the MOH was supportive of task shifting, but no mention of task shifting in the ART guidance of then, of 2011. There was no mention of task shifting. These guidelines which Katavira writes, you know Professor Katavira? He's the one responsible for those guidelines. There was no mention of what? Of task shifting. Okay, then I had to change my study design to describe the study to document how to and what it costs, rather than whether task shifting is effective or safe. So you see how you change your study? Of course, it was much more elegant before, because there was going to be a randomized control trial of comparing task shifting to not task shifting. But that had already been done. And that was not the need. The need was in how to. So it became a descriptive study. So then forming the research advisory committee. So we had to get the stakeholders, and the first meeting we had was attended by 15 people, but subsequent meetings were smaller, but still they kept coming, and we also continued meeting over conference calls. I presented the study proposal approved by the donor. So you have to know also there's a challenge that as researchers we're in between two places. The donor gives you a certain amount of money. I'm sure Professor Msoke knows that. And then stakeholders are telling you to do this, a whole lot of things. So you have to negotiate between the two. And you don't want to come to promise stakeholders things before the donor approves. So you need to have some backing before you come. So I had a proposal that was approved, including the budget. But then I came here now to present it to the committee. And so what the committee could change by that time was not the overall structure. It was too late. But what they changed, what they helped me with, was in selecting study sites. And so you find that the committee becomes very, very important at that stage to select study sites. But the number of study sites, you've already quantified them because you need that for the budget, for the donor to support you. So So you are in between those two. Okay. Then engaging stakeholders in data collection. So what we had to do was to give each of the aid service organizations, the ones that we were going to conduct study with, to give them a small grant for conducting the data collection. So we issued them a small grant to hire and train the data collectors. So that became very participatory. But to ensure objectivity, we got a separate independent data coordinator who was not belonging to any of these organizations, who was reporting to me in Washington. So she was hired, she trained and supervised them and got the data and collated it and sent it to me. So while we were using the service deliverers to recruit and supervise, to recruit and pay the data collectors, they were being supervised by an independent research coordinator. So data interpretation meetings. So we had to have separate interpretation meetings for TASO, for Kitovu, and Uganda Cares. Why do you need to have fast separate meetings with these aid service providers? You've done work on their services. Why must you make sure that you show them the data before you go public? Yes?
I think they may have their own objectives and kind of guiding principles, and you need to see that you are probably working within those guidelines.
Yes, that's very important. Another hand? Yes?
I think also that interpretation of the data is important.
Yes.
Because when you do go to, say, for example, CBC and you say whatever you say, it should be tallying with what they are saying.
Exactly. So, researchers, unfortunately, we are auditors. If you are independent, in your mind you are an auditor. When you come to do research, you find things which may not be comfortable for an organization. So you don't want to go and present, let's say, especially if you are funded by either like CDDPs, as you say, to present these findings to Kabatesi before you share them with what? With the organization. So we found some things which are not working well. So we had to present them. They went back, they checked left and right, they confirmed, yes, it is true that this is what the grant said, this is the situation. So you always have to do that. Then after that, we went to USAID and CDC and went all of us together and we presented these findings. Again, because the donors also, they have an image. So when they are funding services and is a very a key finding that they are not comfortable with, they don't want to hear it from the news. So we have to present to them, show them, and explain to them, these are the things. Do you want us to do any more analysis or anything so that they are sure? Then we began this analysis and writing workshop. We convened people in Jinja, and then we developed a draft manuscript, which eventually got published. So then we had the big dissemination. The big dissemination, after you are sure and your report is ready, you usually hold it in a big place. Okay, we held it in the Sheraton. So we got the big shots from the Ministry of Health. Dr. Joshua Musinguzi himself came, plus all his people responsible for different aspects of HIV care. The adult care, pediatric care, PMTCT, and HTS. So this was very important that they come and hear the findings, all these people. So what were the key findings that we highlighted? One, we described the tasks that could be safely delegated to lower cadre and what training was required. So for example, at that time, because the initiation of ART was dependent on CD4 counts, so that decision to initiate a patient on ARVs based on CD4 count results was waiting for a physician. But in ART task shifting, there was no reason, because the results are back, the CD4 counts are back. The cutoff point is known. So then it was being safely delegated to the nurse. If the patient is below a certain threshold, maybe it was 350 at that time, why not start the patient on ARTs? And the dose is known, the dose of ARTs. So that was doable. Things like getting the patient's files and preparing them in order before the clinic starts. That was safely delegated to what we called the people living with AIDS. We called them expert clients, and that was being done safely. So that's what we demonstrated. Then we also demonstrated, although this was not supposed to be an effectiveness study, we demonstrated that among the patients on whom we had data, those who had attended the community drug distribution points, which TASO was doing, when we compared them to those who had remained attending the non-CDDP clinics, they had a higher retention rate because they were getting ARVs near home and they were getting them consistently. Others, those were supposed to come to Mulago for those TASO Mulago for their ARVs, sometimes they failed, so they had a lower retention. And of course, not very scientifically valid because we didn't have a comparison. But when you do these kinds of intensive monitoring and evaluation, you look at the statistics and you try to glean what you can from the statistics. Then look at the cost, and the annual cost was 404 for Kitovu, 332 for TASO, and 257 for Uganda Cares. And Kitovu Mobile, why? So that was a painful thing for them to note, that this whole process of getting health workers into a four-wheel drive car and driving deep somewhere there and doing the ART clinic there, in the end it was more costly than those who had health workers based attestation and only taking ARVs. That was the model. They only took ARVs with one cancer to distribute ARVs as opposed to taking a whole group of health workers there. So anyway, so took this painful pill and utilized it. They decided now to also delegate to work with existing primary health care facilities in those places where they were doing the mobile facilities, mobile services. So, utilization. And this is where the challenge comes. I'm going to make a lot of claims here which I'm sure you're going to dispute. So, based on our findings and other studies on task shifting in Uganda, in December 2016, the MOH published the Consolidated Guidelines for Prevention and Treatment of HIV in Uganda, in which CDDPs, the TASO's community drug distribution points, are recommended for reaching clients in remote areas with poor accessibility to health facilities for ART. These guidelines also clearly delegate ARV prescription to nurses and midwives, a role previously performed by physicians, and the packaging and distribution of ARV films to lay providers. So those are there. Now, I make this bold claim that based on our findings. Of course not, because a policy is changed based on a build-up like clouds building up before it rains. It's a build-up of evidence. So a lot of evidence was building up. When you look at the literature, I'll say, Wanyenze, Talisuna, you Google their names, you will see how much they're doing on ART task shifting. So our study came in really just on an opportune moment when they were ready to go. Everybody was convinced. So the guidelines now clearly state, you can go there, I've shown you here. So to our knowledge, this is the first time the Uganda MOH guidelines have formally spelled out the role of task shifting in ART care. That is the purpose of research. That's why the reason why I gave you this story is because it is complete. It shows you all these steps. That's what we should be doing. Okay, so what we recommend then? One, we recommend that assessing the stakeholder and policy landscape is key to RIU success. So efforts to encourage RIU should seek to understand the times and opportunities for influencing policy program change, together with contextual factors that may influence decision making. So you have to know, when do they change these policies? like now we have the National HIV Strategic Plan. Do you all know about it? Hey, and you're doing work on HIV. We have a National HIV Strategic Plan. It has got dates, like from 2011 to 2017, for example. And so you have to know when are they going to change it, so that you know when to present your findings, so that your findings can influence that. Yeah. So yeah, give the example of PMTCT. So again, you have to know when they change it and what are the program gaps, so that you can engage stakeholders at the right moment. The second one is research advisory committees or technical working groups and vital forums to engage with stakeholders. So in some situations, there is a ready-made technical working group, like I think for pediatric HIV. So you don't need to form a different one. You can use that technical working group. And so you need to present your study objectives and methodologies. They will ask you questions for clarification and give input in the study design and methodology, as well as practical aspects of how to engage the members of the study population. So when they give you that input, for example, as I talked about MSM, they help you. So their input is not only to make you change the study, but also to help your study. So they can give you advice, which are the MSM groups, that where are they, and where can you find them, and then they will guide you. So stakeholder engagement is an active process of mutual accountability, and this is very important. When researchers present study results, stakeholders ask clarifying questions. You need to write them very carefully. Professor so-and-so has asked this. Professor so-and-so has asked this. Mr. So-and-so has asked this. Then they ask even how study questions are asked. They also provide context to explain the findings and their implication, and sometimes ask additional analysis to be performed. You're presenting your raw data, your frequencies, and they ask you for more analysis. Let's say if there was someone there who is concerned about gender, they'll say, but how do your findings differ by gender? Okay, that person looks at these studies with a gender focus. So you write that down, don't ignore, because she is going to wait to see your report whether it did that analysis. You promised that you're going to analyze the data by gender. So you respond by analyzing and presenting this data at subsequent engagements. Let's say technical working group. You can still call them back and say, can I present to you now after the initial meeting, before I go public with this data, I want to present to you again. So fostering this kind of partnership can engage in mutual accountability, ensuring that stakeholders also follow up on what they promised, because you are also following up on what you promised. So stakeholder capacity and skills matter. So we say that the need for a strong capacity of research users, these are the stakeholders, to acquire. So they need to know how to acquire knowledge. Because these people are, let's say for example, seated down and they're developing guidelines. And they're sitting in a room like this. And they're going to use guesswork to recommend guidelines, to recommend something in guidelines. So we need to build their capacity to do literature review, so that at least the studies that have been done in Uganda are considered when they are making these guidelines. Otherwise, they will just say, no, that doesn't work. In our place, we use this, so let's put this in the guidelines. So to acquire, then to assess. Assessing the quality of data is also very important, because not every study that is done should influence policy. They have to assess the quality of the study. Was it a good study? What is the sample size? Is it generalizable? Was that a good randomization? The sample that you picked, was that representation of the population from which now you want to generalize? So they want to assess that. Then they need to adapt. If research was done in one place, it may not apply exactly the way it was done in that place. You need to adapt it a little bit. And then finally they need to apply it. So that capacity, we need to build it. So during scouting visits, when you're doing a study, when you're visiting that place where you want to conduct the study, let's say you want to do the study in Kayunga, you need to assess the capacity of the stakeholders in the Kayunga district. Are they able to understand research? Do we need to train them on the basics of research before I bring my study findings for them to interpret? Okay, so you need to develop a strategy. So for SOAR, our strategy is one, working side by side but with our co-investigators who are developing country researchers and program and policy decision makers. We are required to have, for each study, as I showed you now, for the SOAR studies in Uganda, I mentioned the names of Ugandans who are investigators on those studies. We are required to have local investigators. And so the way we build the capacity to work side by side. And such a sharing capacity, you know a lot about the situation here. The person coming in from outside may know a lot about science, but may know nothing about the situation here. So you need to share that capacity. That's one. Then, we have also created a small grants initiative to strengthen research utilization capacities of co-investigators. And today we will have 2 of them presenting, knowing that what was approved in a research study, the money may not be enough for you to engage more stakeholders that you want. So your donor should be flexible to give you more funding to enable you to engage the stakeholders quite effectively, because otherwise all the study that you've done doesn't reach the final product just because of a small amount of money, like maybe $500 or $1,000 to reach those stakeholders. So it is important. Like now, my sister said I had to go to districts. So you may find that that money for reaching district by district was not there in the plan, but it's very important. Then conducting regional capacity strengthening workshops. So we also conducted a workshop to where we gathered our stakeholders in South Africa. We conducted twice, where we build our capacities, and we took Professor Mayanja, Hayat Mayanja, and Dr. Coutinho, and others, and they gave input into researchers on what it means, how you can build your career as a researcher. So making data readily available and in digestible formats, that's very important. When you make the data available, people can begin using it even before you finish your study. And that's where we get into conflict with hardcore researchers. They want their study to be finished, data to be validated and published before you present them. But in SOAR, we are encouraged. The donor wants us to share preliminary findings because we are responding to an epidemic. They want to use the results here and now. So for example, these 2 examples which I'm giving here, there was a TB clinic. We were studying TB contact tracing for people with HIV who are diagnosed with TB. We find their contacts, we go and trace them, we bring the contacts, we test them if they're actively with TB, or if they are not, then we give them INH. Now, this study we did it, and we were showing, we disseminated data to South Africa, to clinic managers. We gathered them at the first round of quarterly data. And the clinic managers saw that they had a big gap in terms of how many of these known contacts they were able to trace. So they went and trained their community health workers to begin tracing more. Now, you the researcher, now you are saying, my study, I'm waiting for the impact of my intervention at the end. Now you're already corrupting the intervention, isn't it? You're already training community health workers to go ahead and begin improving the contact tracing. That is the reality. That's what we want. So you should be able to accept that and be able to analyze your findings in such a way that you can still show when this intervention was done. That's why documentation is important. There will be a graph which will show that it was low or moving slowly. Then there will be a spike in the percentage of contact traced. And then you need to document that at this time, the community health worker training took place. And that's why there is a spike in the outcomes. So that's what all you're supposed to do. Document that. Don't say that they're now spoiling my study. There will be no difference between this group and the control. Okay. The same thing we also did in South Africa, a study on provider-initiated training, testing and counseling. So when we did we followed the patients as they were walking around. We found that actually the problem was that with provider-initiated testing and counseling, patients wait the whole day. And then when they see the provider, that's when they are told that you also need to be tested. And they've been waiting all this time. So it is too late at this time. They also want to go for their other labs and so on and so forth. So this group said, why don't we do the testing to those who are waiting before they see the clinician. Because you are sick, whatever you are suffering from, we are saying you should take an HIV test. That's what provider-initiated testing is. It's almost like mandatory testing. You come here, we're going to offer you the HIV test. Of course, you are free to refuse it, but so they began offering it to 80 patients, and that improved the numbers. So they can use findings there and then. So finally, knowledge translation approach strengthens relations and dialogue. So a key barrier to RIU is often the lack of dialogue between researchers and decision makers. To address this barrier on a sustainable basis, we recommend the knowledge translation approach, which, as Professor Sawanka has mentioned, we have Daniel here, who's working on it. And one of the definitions which I like about it is defined as a process that focuses on building trust and dialogue. Okay? It's a relationship, trust and dialogue among researchers, policymakers, and other research users. A knowledge translation process is usually led by a trustworthy, highly recommended, and credible expert, an intermediary who excels in the worlds of both research and policy, like Daniel here. That's what it requires. Someone who is known in both worlds, okay? He's a researcher, but also he has been involved, he knows policy making and guidance. So that's where you end up with people like me, research advisors. You need a facilitator, and I'm happy that the medical school has now someone to do that, because both worlds need to be brought together. So, in conclusion, I'm going to hand over to my colleagues who are going to present case studies of this kind of work that we're doing right now. What I presented was what we did before, but we want also a case study of what is being done now in research utilization. So thank you very much.